All. Welcome to the 15th webinar of AOMSI Kerala. I request the Joint Secretary of AOMSI Kerala State Branch, Dr. Anand Shayer, to make the welcome address.
Good evening, all. I welcome all the participants of this webinar to the 15th online webinar of Orland Maxillofacial Surgeons of India Association Kerala State Chapter. We have our esteemed speaker, Dr. Senthil Murugan, sir, to talk about the reconstruction of maxillofacial defects, options and challenges. I am very sure that he'll enrich us with a lot of knowledges. And today's moderator, I would like to introduce the moderator for the day, Dr. Sudheesh Manoharan. Dr. Sudheesh Manoharan is the Senior Consultant in the Department of Surgical Oncology, MBA Cancer Center and Research Institute, Calicut. So currently, before reaching this position, MDS was completed from Government Dental College, Kottayam in 2012, and Fellowship in Head and Neck Oncology from Malabar Cancer Center, Talasheri in 2014. And to add on to his credits, he has achieved the Fellowship in International Board of Specialists in Orland Maxillofacial Surgery and MOMS RCS in 2018 from Royal College of Surgeons, Edinburgh. So, sir, I welcome you to be the moderator for the session. Welcome you, sir.
Thank you, Dr. Anand, for your kind words. Reconstruction of maxillofacial defects is actually a very complex and challenging area as far as a surgeon is concerned. And to discuss this complex topic, we have none other than Dr. Senthil Murugan with us today. And Dr. Senthil doesn't require a formal introduction actually, because he is a very senior person. He is an Indian board certified maxillofacial surgeon and currently serving as a principal of Savitha Dental College, Chennai. And he's the director of the Dvija Reconstructive Training Center. And he has been teacher to a lot of maxillofacial candidates. And without any further ado, let me hand over the podium to Dr. Senthil. Sir, please. Senthil, sir?
Yeah, I'm here. 1 minute. Thank you, Dr. Sudheesh. Thank you, Dr. Akhilesh, for this wonderful opportunity that you have offered me to share some of my inputs on this wonderful evening. So let me straight away go into the presentation on reconstruction of maxillofacial defects. It was challenging, as Sudheesh was mentioning in the introductory lecture. It was challenging not because the process is difficult or the other things, the skills are compromised with the maxillofacial surgeon. However, it is because of lack of training, which was existing for a long period, more than 3 decades. Though it started by a maxillofacial surgeon in 1997, the first of its kind. Later, that was not progress because of lack of training. So that is the only blocking criteria which was leading many of the maxillofacial surgeons not to go for this kind of procedures despite so much of skill. So let me try to overcome some of my obstacles that is seen by the maxillofacial surgeon when they start doing this reconstructive surgery. And also some of the cases that we are doing on very regular basis. So that will make the people to understand easily as well as for the PGs to go for exams. So let me thank once again the AOMSI, entire AOMSI. It is second home for me almost, like more than 30 years of association. Now most of my batchmates are hailing from Kerala. So my association with Kerala is not less than 25 years and I'm really, really happy to be with you right now. So what are the anatomical intricacies that is faced by the maxillofacial surgeon as far as maxillofacial surgery, maxillofacial region is concerned? One is aesthetic component. Being a dentist, hailing from a dental background, we all think in terms of cosmetics first. Aesthetic is the first and foremost things, and then only think about the functions. So these are two components which make the maxillofacial surgeons to, difficult to manage those things. So difficult to balance these two in all together. So in that way, what are the areas that is really challenging for the maxillofacial surgeon? One is the nose, second chin, third is the malar prominence, and the fourth is the jawline. And functional components, most of the maxillofacial surgeons face problem with the tongue function, that is sensory or in the motor innervation. So either it could be simple procedures starting from the minor oral surgical procedures or advanced procedures like microvascular surgery. Eyes and lips are considered both as aesthetic as well as for the functional, considered as a functional components. So if that is addressed properly, then most of the problems are solved for a maxillofacial surgeons in the clinic. How the defects from where the defects result. One is from the high velocity trauma, and the second is the gunshot injury. Most of these kind of injuries to the facial will deteriorate the form and maximum to the function for a very large extent. And the second thing is, not all the problems can be addressed in one surgery. When the patient come to us with maxillofacial injuries, we need some kind of secondary surgeries also. It's called secondary deformity correction. And second is the infection. Osteomyelitis, most of the patients, 90% of the population is becoming a diabetic capital. India is becoming a diabetic capital for most of the countries next to the cancer. And mucormycosis, in recent times, we are having a lot of mucormycosis with the black, white, yellow, all kind of fungus, which is completely spoiling the facial form, especially the maxillary arch, mid-third of the face, and sometimes patient lose the eyes. Third is the main domain of this presentation is the ablative operations for neoplasms. The patient comes to with very advanced stage of oral cancer or many of the benign lesions to have very advanced presentation, which cannot be treated conservatively, which maintains the form and function of the facial bones. So in that case, such ablation, why we do ablation is to overcome the recurrence, to prevent the recurrence. So in order to do that, see, we have to compromise, we have to lose some of the main structures of the facial function. And it badly results in a very awkward appearance as well as the deteriorated functions. And the fourth is the osteonecrosis. The term osteoradionecrosis has been replaced with osteonecrosis and histronecrosis, mostly medication-related osteonecrosis of the jaw. For example, we give pamidronate, aminobisphosphonate for fibrous lesions. So that causes osteolysis, and that can result in some of the form of necrosis, ischemic osteonecrosis. And the last is the congenital deformities. For the commonest congenital deformity faced by the maxillofacial is the cleft palate. Some of the cleft palate may not be corrected conventionally. In that cases, we need to think of something else. So basically, how do we classify the maxillofacial defects? Divided into maxilla and mandible. Mandible is by Boyd is the first person who did this major correction based on the extent of the defect. The hemimandible defect, which is from the midline to the condyle. This is called hemimandible, complete classical hemimandibulectomy defect. Number one, it's called H defect. The second is a central defect, anything between the ramus, two rami, angle to angle, that is called central. And third is the lateral, more or less similar to the hemimandible, but preserving the condyle. The whole thing is called lateral. It could be from midline to premolar, it could be midline to molar, or it could be midline to coronoid, midline to ramus, but condyle is preserved. That's called lateral defect. Why I keep on, this is the commonest classification which is being followed theoretically as well as in the practical application as well. So we need to know about this classification. Other classification, Boyd's himself modified in 1993 based on the content that is being lost. O or zero, both are same. O means osseous, or zero means no loss at all. That could be the one. S is the skin. Third is the mucosa. This is Boyd himself modified this HCl into these three classifications. Arkin 1991 CRBS, that is condyle ramus body symphysis classification, that was done in 1991. Robert Brown is the first and foremost who employed classification for both maxillas to the mandible based on the function. The rest and all anatomical. He combined both anatomical as well as functional into his classification. Schultz types again 1, 2, 3, again more or less to the Robert Brown, but again it comes into the prosthetics as well as for the replacement of Robert's classification. You can make a note of the journal that we obtained this kind of classification from this. You can make a note of, or I can share the whole presentation to you guys. So maxillary defect will be like this, on anterior maxilla and the palate, or combination of these three. This is the one thing which been done by Brown's classification. He himself revised this, the latest one, which is done in 2011. So based on this classification, we design what kind of treatment has to be done. Harmony post-maxillectomy defects in 1978. This is basically meant for placement of the obturator, not for surgical procedure. However, we surgeons can take this into account for applying, instead of obturator, we apply some amount of tissue into that to replace that. So Brown and Shaw, again 2010, it was modified. Later, Ongren, hope you all know that Ongren's line, the line which is drawn from the medial canthus to the angle of the mandible. If the lesion is go above the line, that will have a bad prognosis, right? The same Ongren has designed this classification, and Spiro in 1997. Some amount of minor classification corrections has been done, but it based on the situation that matters. But basic foundation is Boyd's and Robert Brown's. Boyd's and Brown's, B&B. Mandible Boyd, Brown for maxilla. This has to be clearly understood. So what are the principles that we follow for doing the reconstruction of maxillomandibular defect? One is protection of the vital structures. See, the presentation is basically on the extensive surgery, minimum of extensive amyloblastoma, maximum of cancer surgery. That is the main idea of this presentation. Then and there we touch some part of the trauma and the distraction osteogenesis in between, and for the exam point of view. So protection of vital, what do you mean protection of vital structures? We all do that neck dissection for all kind of oral cancer patients, right? So what will happen? We expose the carotid sheath to remove all the levels of nodes. So that is left exposed. Secondly, that neck dissection will not be left as it is. We send the patient invariably for all the patients for radiation. Once that comes, it needs a protection. There is no soft tissue over that. So basically that needs a protection that we need to give a cover. Second is the covering the defect. The covering the defect, for example, the cheek section is, we can't leave it like this. We have to close it either primarily if possible. Otherwise, you have to go for something else has to be placed. The second is, it acts as a diaphragm. If the flap or any material that we keep it inside, it should act as a diaphragm. It should prevent the, for example, if you are sacrificing a maxilla along with the palate, and you will have a nasal regurgitation and evacuation of discharge from the oral cavity to that. And infratemporal fossa, the retrograde spread of any contamination should not go into that. So we need a seal for that. Similarly, for lower jaw, mandible, if you sacrifice mandible for a purpose of excision of the wide local excision of your CA, so the floor is lost, the mandibular floor is lost. So there should not be a seepage from the oral cavity to the neck. So that is a basic idea of doing the reconstruction. And form on basic functional restoration, that to some extent, whatever we can get, not like how we get it done in proper cosmesis, but to some extent to form and basic function like chewing and swallowing, speech, those kind of basic functions are certainly restored. What are the options? What are the reconstruction that can be done? Not all patients need flap, not all patients needs PSI, not all patients need distraction. Some patients need not go for reconstruction, or some patient could not be done with reconstruction, that no reconstruction with or without IMF. That is the one. Second, conventionally, what we practice is the reconstruction plate. The reconstruction plate, it acts as to some extent, it maintains the form, harmony of the face. For example, one side of the mandible is sacrificed, another hemimandible is left. Whenever the patient tries to open the mouth, the existing mandible gets played to the space, right? To prevent that, we have to keep something. Either you can keep IMF with the existing mandible. How the IMF can help you? The IMF, keep it for 4 weeks. The contracture of scar of the resected area will act as a barrier which prevents the arch collapse. That is the one idea. Reconstruction plate, similarly, it acts as a mandible, but then you can't put a teeth, either conventional or implants. Third is the non-vascularized grafts. The non-vascular grafts is not at all meant for your cancer debilitated or cancer ablated patients. It's only for the patient which is small defect less than 6 centimeters. Small segment, last defect has to be can be replaced with your free graft like iliac crest or fibula. make sure it should not be a cantilever. Even the defect size is small. Both sides should be the strut should be supported by the native mandible. Otherwise, that will also go for melting. Next comes the flaps. It could be again local, different types of flaps that we are going to discuss in detail. Transport distraction, one of the amazing fields of doing the restoration of any kind of lost part, but it has got lot of limitations, especially when it crosses the midline, when it is tried for long defect from angle to angle or even major defect, then that will be a challenge. Why it is not the patient has to have that cumbersome device for more than 3 months until the newly formed bone should get consolidated until then the patient has to have that. And it has got a major restriction is cancer patient cannot undergo because we send the patient for radiation or compromised blood vascularized area, the bone will not form. That is a restriction for distraction. The next is the tissue expansion. Tissue expansion it's mainly meant for your burn patients. So complete contracture. Some healthy tissue has to be there. Otherwise, that is also going to be a challenge. Tissue engineering, lot of new things have come. Stem cells, bone morphogenetic protein, those kind of modified, human own bone is getting modified and sent for, placed in the place where the defect is there. Say, for example, for bone morphogenetic, it is nothing but a demineralized cortical bone, basically. Then you can also obtain from the cancerous bone. So that has to be demineralized. So that is like allograft only. So that can be placed into that. That needs some scaffold. Some of the pictures, this patient doesn't require reconstruction. You can leave it like this. You can leave it like this with close the skin alone, it will granulate because there is no anatomical barrier which is being breached. The floor of the mouth is intact. The patient has undergone a peripheral osteotomy. You can allow to granulate, that will heal. This kind of patient doesn't require reconstruction. As I said, no reconstruction for this case. The other options, as I discussed so far, one is the reconstruction plate. You can appreciate the mandible is still intact on the other side, and the rest of the space is occupied by your reconstruction plate. Most of the benign lesions undergoing such wide resections can be used with this. So the advantage with this reconstruction plate is if at all the patient wants to go for a fibula or a late reconstruction, this plate acts as a plane for easy placement of your flap or graft. So that is the one advantage. Second advantage is if the patient doesn't want permanent prosthesis, you can manage with the plastic or resin process or conventional process, whatever the patient we can prefer. The second shows the angle-to-angle defect done intraorally. Reconstruction plate is placed and just prevent the ramus collapse, and the tongue is stabilized with the plate. The tongue fallback is greatly prevented by doing this plating, but then you can't replace the last teeth. That is the major disadvantage, but this is meant only for benign lesions. The one which is seen is the flap, local flap, regional flap. Regional flaps, like this is the deltopectoral, and inside the closed area is pectoralis major. The patient has got a huge defect. Patient cannot undergo long procedures like microvascular surgery, 8-year-old. So in that case, intraoral lining is given by your pectoralis major flap. The outside skin covering is given by the deltopectoral flap. The pectoralis major flap can be intact, it can be kept inside as it is, and it will completely get mucosalized. Whereas this flap has to be divided after 3 weeks. Once you are obtaining this cheek skin, you can divide at the root of the flap and do a primary closure on the chest. This is the one flap which can be done. The one which we are seeing is the free graft, which is meant for small defects, as it's a child's play for any maxillofacial surgeon to do a iliac crest free graft, cortical cancer strut at any extent he can do. 4-dimensionally, the maxillofacial surgeon can manipulate this. Why I'm telling this is because this same principle for your deep circumflex iliac artery and the vein, ilium flap can be used. The same principle, but little extensive dissection, that's all. The one which we are seeing is the transport distraction. We never tried this transport distraction, but then for the purpose of postgraduate students, some body small defect, biplanar defect, biplanar distractor can be placed, and one stable point is anchored and the rest can be moved from one part to another part. We all know that the latency period is 7 days, 5 to 7 days. And then you have the activation for 10 millimeter, not more than that. You can do only 10 millimeter. 1 millimeter per day is even now it is still the same concept. And you can do it in increments, morning 5, 0.5, evening 5, like that, or 0.25 into 4 increments, you can do a distraction. But then only 10 millimeter bone can be distracted. Until the bone is getting consolidated, new bone is consolidated, the disease have to be owned by the patient. So that is one challenge in this. The last one is the tissue expanders. Healthy tissue should be there neighboring to the defect. That is more important. If that is also unhealthy, then this will not work. So tissue expanders, it's only expands the soft tissues. Color match is very good. And the patient has to wait until the tissue gets expanded. And another challenge is you can't use it for cancer patients because all the peripheral is also getting vasculitis jeopardized. Selection criteria, primary, when do you want to do that? Do you want to do the time of primary surgery, cancer resection or amyloblastoma resection, OKC resection, do it now or later? That is surgeon choice number one for benign lesions, not for your malignant lesion. All the malignant lesion has to be restored by flap. Primarily, it has to be done if no reconstruction is planned. If there is no need for reconstruction, you can leave it like this. Whereas there is a defect which needs reconstruction, you need to do it immediately. You can't take a chance for secondary. Primary and secondary both can be applied for your benign lesions. What are the advantage? Primary one time, simultaneously you can do. Second is healthy bed for adaptation. The patient is fresh of tissues, so you can handle very easily and manipulate easily. Vessels are intact. If you close it and leave it like this, it will become tethered when you open for second surgery. That is not there in the case of primary. And mandatory neck dissection. Primary you can't do, as I said, the cover has to be given for the carotid sheath. In that case, you cannot do secondary or do primary only. Disease-free period is a challenge. For example, if your multiple attempts have been already made for OKC, for example, we have seen a lot of cases in that. They do conservative, over 6 months, 1 year, the patient comes with the recurrence. Again, at one point of time, complete all shelled out bone patient will come with that kind of structure. And the patient will be subjected for resection. And if you do a reconstruction, that will be a challenge because it can come back. If the patient has the tendency to have a recurrence, it can recur on the grafted or flap treated bone also. So first attempt is the best attempt. So the disease-free period is a challenge. So how long can you wait? We don't know. So that is the one disadvantage, the primary. Coming to the second reconstruction, disease-free period can be assessed. You can wait for 3 months. Once you getting rid of all those disease, wait for 6 months, 1 year, you check with PET scan, then you take it for surgery. That is one advantage. Most of the post-traumatic case, secondary deformities are addressed by leaving. You can't achieve everything in the primary surgery itself. So we need to wait for some time. And what is the resultant defect, residual defect, then you go for your reconstruction. And third is the compromise and depleted neck. This is the greatest challenge when you go for second reconstruction, especially when you do a cancer resection and send the patient for radiation. You send it with pectoralis major or some other flaps. If it is exceeding 50 grays of radiation, definitely that will deteriorate the existing flap. So the neck is already jeopardized with your surgery as well as the radiation. That is a challenge. Plane of dissection will be very, very difficult when you do a second reconstruction. Either it could be a primary, it could be a benign lesion or it is a malignant lesion. Malignant even more difficult. And the advantage is disease-free period can be assessed. Comfortably you can do. Or I'm saying the patient doesn't have any disease, then I take the patient for reconstruction. Disease-based, all conventional method can be tried with your benign lesion, defect resulting from the benign ablation. And secondary reconstruction is mandatory in some situations. So in that case, you can compromise with your benign lesions. Third is the advanced methods can be time tested. You can try some other new methods like your stem cells or whatever. All those things can be time tested when there is a benign lesion defect is there. And in the case of benign defect, the defect determines the reconstruction. That means how much ever the defect, residual defect after surgery, first surgery, that is determined by the defect. Whereas in the case of malignancy, the lesion determines. For example, the patient comes with the T4 lesion. You send the patient for subjecting the patient for surgery. You do excision. You send the specimen for frozen. They are not happy. Again, you go some kind of dysplasia or whatever it is there. You just send the patient again. You excise. That keeps on expanding the defect size. So until the primary surgeon comes out of that area, the flap harvesting or secondary, the reconstruction has to be planned is difficult. And primary reconstruction for all malignancies mandatory, no other go. Third is the radiation dosage challenge. See, mandible can withstand only 5,000 to 6,000 centigrade, 50 to 60 grade. If it exceeds, the normal mandible will go for a toss, will go for a osteonecrosis. So radiation dosage is another challenge. If the bone is involving, if the depth of invasion is more than 1 centimeters, then definitely they'll go for higher form of radiation. In that case, reconstruction of the bone will be very difficult. So that is one challenge. What is the reconstruction? We should have a lot of B plans. We should always have, we cannot stick on to only one flap that can address one of the methods to address. We need multiple, right? So in that way, earlier it was the other way around. This is the revised reconstruction ladder. Earlier it was primary closure or secondary intention of healing. Later, if that goes for a flaw, then it become a other stage, local tissue transfer, all those things. Now they advise to go from the bottom. You should see free tissue transfer. Free flap should be done first. Why they change this? If you do all the attempts earlier, primary reconstruction, primary healing, secondary healing, all those things, all goes for a flaw. The patient comes to you, it is very difficult to obtain a proper healthy bed for doing a free flap, right? Complete scarring will be there, patient cannot open the mouth, all those things will be there. So what they strictly advise is, you should start the free flap. If that goes for a flaw, then you think about the other methods of reconstruction. So what does it mean? The options are open and multiple options can be taken into account when you plan for a surgery. That is a plan B. So this is the reconstructive guidelines, which is given by Brown and Ragbir in 84. Since then, it is being followed now. So different between a flap and the graft. Flap possesses blood vessels along with the graft. When the graft is attached with the blood vessel, that becomes a flap. Whereas graft doesn't have any blood vessels, whereas it is completely removed from the donor site, and it has to be placed in the recipient site. Neovascularization from the recipient site has to make the graft to survive. So larger, deeper defects, better to go for a flap. If the recipient bed is fine, then you can think, if the defect size is small, then you can go for a free graft. Fourth is a radiation exposure should always be in the mind of any maxillofacial surgeon who practice reconstruction for a CA patient. As I said, 50 is the deadline. If 50 is exceeding, definitely even the flap will have some issues. So what is the local flap advantage? Local flap is within the oral cavity, close to the defects or local flaps. Best local cosmetic match will be there. Simple. And sometimes you can do it under local anesthesia, regional anesthesia. Sometimes it may require general anesthesia. Drawback, you can't address all the defects using this local flap. It should not be it should be a tension-free closure. So that will not be happen sometimes. When there's a shortage, it will give up. Once it gives up, then it is very difficult to do a primary closure again. And scarring, if you keep on multiple attempts when the scarring is there, that will not allow for a proper healing. Compromise clearance of the disease. See, that's what Ian McGregor insists. The reconstruction should be done by the reconstructive surgeon, whereas ablation should be done by the separate, because the ablative surgeon should not do free flaps or flaps, because it will have a compromise mindset to preserve some amount of native tissue, right? So it should be two different teams, two different mindset. So in that way, two team is very much important to get rid of this disease. All together, we have to get rid of this disease only. So how do you classify the flaps based on the location? It could be local or loco-regional. Local is intraoral. For example, Greater Baldwin is a local. Loco-regional is your nasolabial or your submental, which is confined within the face and the buccal pad of fat. Those things are very confined to the maxillofacial region. Distant is again classified into free and pedicle. What is distant flap? It's much away from the head and neck area. It could be a pectoralis major, it could be your deltopectoral pedicle flaps, but distant. You understand? The last but not the least, the free flaps, completely away from the defect, as well as we remove along with the blood vessels, and there's a distant free flaps. So based on the movement, local flaps can be advanced. How you advance with your buccal and for closure of your orovantral fistula, and rotate again orovantral fistula with your pedicled greater palatine flap, and transposition from one area to the another, anything it could be. So classification based on, this is more important, Komar-Lamberti and Mathis and Nagai. These two classifications are standard classification based on the blood supply and based on the pedicle. So these two classifications are considered as a hallmark for your theory exams. Mathis-Nagai classification. Abundant sources are present in the human body to support the defect and to close the defect. Either it could be in the form of free flaps, microvascular flaps, or a pedicle flap itself. These are various areas that can be used. Investigation. Any flap should be checked for flap survival based on your blood supply. So first check whether the blood flow is adequate. Second is, after taking this blood vessels along with your flap, the donor site has to survey, should not have any ischemic issue. For that, you need a simple clinical examination like Allen's test or checking the posterior tibial vessels on the medial surface of the leg, or acoustic Doppler, very cheap. 8 megahertz is the vibration that has to be used for assessment of simple perforators less than 2 millimeter. So this is the sound that can be, the same thing can be used for your flap assessment later. This is your dorsalis pedis, and this is your posterior tibial artery for harvesting the free fibula flap. And this is the skin perforators, which can locate your, this is for your radial foramen. Ulnar. So these two alone is not enough. You have to check the palmar arch because the radial and ulnar will join in the palm. So that has to be intact. That has to be assessed. So this has to be checked. And this is for anterolateral thigh flap, the same principle that is being imposed. So how to choose the correct flap? Consider all the options, right from no reconstruction till the advanced procedure or dual flap or chimeric flap, whatever it is. Consider all the options, whichever is applicable for that area. Make sure it should have adequate pedicle length. That is more important. The site of anastomosis should not have any tension at the time of anastomosis, or even when the patient touches the head, is more important. Third is when you think for soft tissue, just take radial foramen is the basic flap for any beginner to employ in this. ALT flap, latissimus dorsi, and rectus abdominis. So these are the 4 ideal flaps for any kind of soft, depends upon the thickness. If you want to go for thick flap, go for rectus abdominis or ALT. And broad flap, you want to take, you take a latissimus dorsi. Radial is the pliable skin, long pedicle, diameter of the feeder vessel is more than 2 millimeter. You can do a naked anastomosis sometimes, depends upon the patient. So radial is the first and foremost. Second comes the ALT. And one thing I want to, radial foramen and fibula are the 2 flap which needs to be harvested very soon. because we applied tourniquet to have a hemostasis, whereas the other flap doesn't require any tourniquet. So tourniquet is tying on the thigh or distal to that site of flap, we tie the tourniquet and inflate. So that gives a compression and there won't be any bleeding from the site of harvesting. So when you go for a composite means muscle, mucosa, bone, everything is involved. That composite fibula is the ideal. When you learn fibula, 95% of maxillofacial defects can be addressed, and 5% by the other two soft tissue flaps. Scapula, and third is the deep circumflex iliac artery, the iliac flap. Coming to the pedicle flap, of course, Aryan flap, PMMC is the first and foremost, last, third, everything is PMMC. Latissimus dorsi can be used both pedicle as well as a free flap, depends upon the arc of rotation. If you have any tension in the site of axilla, then you harvest it separately and do anastomosis like how you do it for conventional. Even pec major can be done as a free flap. Deltopectoral flap, it is again a child's play for anyone. It's just fasciocutaneous flap relying on the internal memory. So that can be harvested, but all these flaps have some kind of limitations. So based on that, we choose the flap. Supraclavicular flap and the small flap, but it can go up to some amount of neck and the lower jaw. As I said, always have a plan B and C. Different option has to be there. So that is the one thing you should keep in the mind. Let's come few of the problem-based issues. Tongue is the first and foremost. We have options like no reconstruction. You can do a primary closure, rotate the basic tongue, a remnant tongue, and do a closure. But then some cases need your flap. How the flap helps in your reconstruction of the tongue? It doesn't restore the sense. It doesn't restore the sensation. It doesn't restore the taste. But why do we need it? It helps greatly in swallowing. If the tongue is closed primarily, rotated with the remnant tongue closed primarily, it's very difficult. The patient cannot swallow. Second is the floor need a seal. Most of the lateral border of the tongue will be involving the floor where we breach the floor at the time of clearance. So in that case, we need some amount of seal using some kind of flap. In that way, the primary closure cannot be useful. So this is the outcome of a young female patient who has got this. If at all, if you want to go for a sensor, you can involve the lateral cutaneous nerve from the hand along with that. And this wonderful flap for reconstruction of the tongue, because the pliability of the skin, very thin flap and very reliable. It has got a 3 blood supply, 3 venous drainage. One is 2 vena commitants from the radial artery, and 1 cephalic vein can be called anesthetist vein. No, it is lateral to that. That is very huge vein, which we can get comfortable anastomosis at the site of IJV or common facial vein. So this is one of the best flap for reconstruction of the tongue. And you can appreciate the outcome of the radial forearm. Radial forearm has got 2 types of dissection. One is suprafacial and subfacial dissection. Subfacial is you have to go deeper to the peritoneal layer, and sometimes the skin graft may not take. That is one of the challenges. In this case, suprafacial dissection was done, and the SSG split thickness graft has readily taken up, and we can appreciate a good closure of the wound. So this is one of the modifications which is done since many years. Subdermal radial forearm free flap. So what we do is we are planning to do a subdermal radial forearm free flap, preserving the epidermis of the radial forearm skin, which is kept intact in this part, and only the center portion is taken for using the reconstruction of the defect. The outer same skin can be replaced and sutured. That is the idea of this one. The outer line shows the marking of the cephalic vein, and the one which is inside is the radial artery and its vena commitants joining the brachial area. So this flap is meant for isolated soft tissue intraoral closure. Intraorally, we don't need skin. So what happens? We maintain the skin, the same skin on one area kept intact. We harvest the skin graft first, not dividing at the distal end. We just keep it like this. We keep on, keeping the moisture environment, keep on irrigating with the gauze. And the regular harvesting is taken place in the subfacial plane. Like this. You can appreciate the color of the, pink color of the flap, and you can appreciate the other side is intact. Even if the peritoneal layer is going, this will protect unless you jeopardize some amount of tendon. So it's a wonderful methods, but then you have to be very careful while harvesting the skin graft. If it goes for a flaw, doesn't matter, that itself can be used as your SSG later. Instead of exploring the another normal side, you can do the same side. This is the different, the conventional radial forearm. You can see the palatal closure. You can see a lot of hair growth is in, which is irritating the patient. Whereas this subdermal flap helps complete mucosization very faster and no hair growth issues. So this is one of the best way of doing this. So tongue, what are the other options? Is it only radial forearm? Yes, you can do a thin ALT. Thin ALT, in fact, replacing the radial forearm. Radial forearm is becoming obsolete because of the very bad donor side morbidity. That once the tendon is exposed out of peritoneal layer, SSG will not take. So it causes wound contracture, hand contracture, and debilitation of the donor side. So that is being replaced by thin ALT flap. Just go for a suprafacial dissection of the flap and just take primary debulking, like remove all the in the thigh itself. And primary closure is achievable in most of the ALT, unless it has got a huge volume defect. Primary closure is easily achievable, and hidden donor side. This is one of the best flap. And upper arm flap, again, it is hidden donor side, thin, best for tongue, but then the size of the lumen of your vessel is less, and length of the particular, so too less. Unless you have a good recipient vessel, long facial or your whatever the facial artery or vessel, it's very difficult. Superficial is skin flap, nothing but a skin flap, very, very pliable, more pliable than your radial forearm flap. But short pedicle and lumen is the challenge, hidden donor side. So these are the advantages for tongue reconstruction for using other flaps. Coming to the fibula for benign lesions, it varies what type of, as I said, disease determines and defect determines. So this is defect determined, not the disease. So such a huge lesion which has been excised, resulting with your mandibular defect, almost hemimandibular defect, which is being reconstructed with this flap. So this is one of the best flap. You can do multiple osteotomies. Hidalgo is the first person who proved, Taylor is the first person who invented this, whereas Hidalgo is the person who made multiple osteotomies. Despite doing multiple osteotomies also, the flap can survive. That is the motto of this, done in 1989. Till then, it was only straight flap. 1989, they formed into multiple osteotomies. What is the challenge in this? The challenge is vascular anatomy. Fibula appears in three forms. One is trapezoidal, one is quadrilateral, one is triangular. There are three forms, three shapes only in the cross section. On the other hand, 4 variations in the vascular anatomy. This is more important. A, B, C or safe. D is very dangerous. Peroneal artery magna, which is directly coming from the popliteal vessel. So if you touch without doing proper investigation, the leg will go for a ischemic necrosis and amputation. So how to avoid this? Best, safe, to take a CT angiography and find out and rule out any vascular anomalies there or not, especially when the patient is exceeding 50, female patients. All those, some underlying immunocompromised state, COVID patient, those patients will have a compromised vascular anatomy. Diabetic patients, peripheral vascular is very common. So those kind of things has to be evaluated preoperatively, then you should take the patient. CT angiography is the standard value. The advantage is you see the vascular disease is there or not. Second is you can see the CT scan quality of the bone and size of the bone, whether to go for double barrel or single barrel. Sometimes you'll have a good width, no need to go for double barrel. Those things can be preoperatively planned when you take a CT angiography. So this various modifications, single barrel, double barrel, you can appreciate the second photography with the double barrel because one strut is so small. So those kind of things can be planned accordingly. Double barrel is advantages. Over a period of time, you can discard the reconstruction plate, even if you put it in that. Second, you can achieve the height of the mandible. And the third is it enhances the implant placement. You can go up to the upper border, full upper border. It is more than 2.5 centimeters. The width is approximately 2 to 2.5 centimeter. You can go up to, that is 20 millimeter. 20 millimeter, you can use any kind of dental implants. But the second challenge between the two barrels, sometimes the soft tissue will never get fused. So what we do is we apply PRF in between that and the junction of your native mandible and the fibula flap, this will be useful. So double barrel is one of the fantastic method. It takes another half an hour extra to do that, if provided the defect size should be less and you should have adequate pedicle length. That is more important. So much of fibula will be sacrificed while doing your double barrel. So plan accordingly. Should have adequate pedicle length to get a comfortable anastomosis. And second is your soft tissue over there. If you are keeping double barrel, definitely you need a soft tissue intraorally, not extraorally. So the height has to be closed with your soft tissue skin from the fibula. In malignant condition, what way it differs? As I said, the radiation matters. When the radiation is you assess before that itself. You talk to the radiation oncologist if you're going for a fibula flap or some other flaps, and you can't do a primary dental implant placement when you do a fibula for the malignant lesions. So benign lesions, you can do primary implant placement in the fibula itself before doing the anastomosis, or you can do anastomosis later with your fibula in the leg itself. So those things are there, which is not at all possible with your patient, those who are expected to go for radiation. So second is, if the mandible itself cannot withstand more than 50 gray of your radiation, the newly placed fibula will definitely get exposed. So be planned to choose the patient and properly convince the patient and discuss with your radiation oncologist how much of radiation is anticipated based on your decision. So this is the one which has been done. And just for seeing the flap, we kept the monitor outside, skin paddle outside, just keep on seeing this. And one point of time, we discard this before we send the patient for radiation. If radiation within 50. Small bony defect, iliac crest can be considered, very lessly practiced for various reasons. One is the patient cannot wear a garment sometimes if you take extensive graft. First and foremost, cosmetically, it won't be harmonious. Second is prone for hernia, unless it is meticulously sutured properly, especially when you go for inguinal ligament, because medial to the inguinal ligament only, you'll see the deep circumflex iliac in the vein. So in that case, you should be very meticulous if you divide your inguinal ligament. And flap-wise disadvantages are very good bone stock. You can put a dental implant, all are fine. Soft tissue, everything is fantastic. But the problem is pedicle length is too short, less than 10 centimeters. If it is a straight defect, you can push. Multiple osteotomy is very difficult to do because the whole width of the iliac should be protected medially, and then only you can make a cut. Lumen size is less than 2 millimeters in some of the cases. So these are the factors which is restricting even the plastic surgeons not to employ these kind of methods. Cheek with the gingivobuccal sulcus. It's a composite defect, ideal for a fibula, but then the problem is we won't get this much of soft tissue for coverage in the fibula. We have to cover the alveolus, floor of the mouth, cheek, inner lining of the cheek, outer lining of the cheek, and the lower part of the mandible. So fibula, you can take a fibula bone, but soft tissue will not be there. So either you should go for double flap or you can think of something else. Patient is happy with your conventional removable prosthesis. We can just seal the floor of the mandible, floor of the oral cavity, cheek mucosa, as well as the skin. For that, we prefer ALT flap based on the lateral descending branch of lateral circumflex femoral artery and the vein. Consistent anatomy, multiple perforators are present. Most of the time, we can do a primary closure in the donor side. No other flap will allow such versatility. It is very easy harvest. You will never have a flaw, and you'll never seldom fails. This flap seldom fails because of its caliber size, comfortable anastomosis, and good volume. You can do a through and through, like how we are seeing right now, can be seen better. Through and through defect can be easily closed. So this is the basic advantage of your ALT flap. For maxillary defects, options, if you want a teeth, if you are going for a less amount of radiation, think of fibula again. You can carve as much as you want. While placing the plate and fixing the flap, make sure your coronary is not being hit by your fibula flap. Otherwise, there will be a problem. At the time of closure, we won't be thinking of such a long procedure. We won't be able to think of that. So what we do, we just try to place it inside, the patient not be able to open the mouth, like a zygoma fracture. So that is the only thing we have to. For palatal reconstruction, there is no need for palate. Palate doesn't have any function at all, as we all know that. So even the hard palate, we need only a seal with your soft tissue. So only the alveolus in the zygoma requires the bone. So in that case, we can go for your fibula, or else iliac can be considered the small defect, and the medial surface of the ilium will go occupy the palate along with the soft tissue, and laterally the alveolar ridge is formed by your iliac ridge. Third option will be a scapula. That can also be thought. And some of the congenital anomalies like cleft, wide cleft palate, adult cleft, not for young patient, pediatric patient we cannot do. For adult patient, we can think of doing this flap, radial foramen free flap. Advantages, no need to go for a nasal layer closure, as we all do it in the case of conventional flap, conventional palatoplasty. We need to do a layer closure, right? Nasal layer, then only oral layer, which is not required here when you use such a keratinized surface over that. And you can do anastomosis with the neck vessels or superficial temporal artery and the vein, depending upon the size of the flap vessels. So that has to be chosen by the surgeon. It's one of the best way of closing the white cleft. Anterior palate, again, the patient is going for radiation. So patient doesn't want fibula. So in that case, we can go for again radial foramen free flap. Just give a diaphragm between the oral cavity and the nasal cavity. PSA supported. PSA is one of the emerging fields. It has come up in a bigger way, but the bad challenge is your soft tissue closure. We just make a replica of whatever the system makes, exact replica of whatever has been lost. Either it could be a cancer patient or it could be your benign lesions or mucormycosis. But soft tissue is the greatest challenge. So you have to plan properly. Why we avoid flaps? In order to prevent your exploring the donor side, right? So when you go for PSI of course, it addresses that problem, but then the problem with the soft tissue closure is very difficult. When you come for mandible, displaying of the device is one of the major, at time, maybe 1 month, 2 months, it'll be okay. Then after that, get exposed. So you need a strong soft tissue support to close your PSA. In that case, radial foramen is the ideal, cheapest. Early, patient can recover fast, and you can harvest very soon and do the anastomosis comfortably because vessels are very good in caliber and long. So these are the advantages with the flap. So in that case, so how we feed? We always prefer radial foramen patients rather than going for superficial temporary because the capillary vein has got a good caliber.
One part is
some amount of distance under the flap is sacrificed.
yeah.
Oh,
shit. Yeah.
Again, you get a good coverage for this, and you appreciate how much of complete closure of your device has been accepted. Just for closure of the device only, you harvest this flap. So the purpose is little compromised by using a PSA. Again, another flap, local simple flap like nasal flap, which gives a good closure for your device. Of course, the abutment are separately connected with this, and the teeth has been restored with your hybrid kind of denture. And this is formed by your nasolabial flap, not radial foramen. Submucous fibrous is one of the commonest defect. Why we do a treatment for submucous fibrous? Not all patients are subjected to surgery. Some patients can be treated conservative, like if the mouth opening is less than 20 millimeter, we try with other methods. And later, if it goes for a flaw, then we think of going for advanced procedures. So what we basically do is eliminate the disease, number one, because it is potential for malignancy transformation. Second is the mouth opening, enhance the mouth opening. That is the greatest challenge in doing your submucous fibrosis, and prevent the relapse. Though the patient can do some amount of mouth opening exercise, not always your mouth opening exercise alone will helpful for patient to get regain the mouth opening. Some normal tissue has to cover that area. That is a basic thing, basic problem with that. So normal tissue obtained from various other sites, not only from buccal pad, for some other sites can also be thought. So in that case, what we prefer, pedicle to buccal pad effect, conventionally what we practice, nasolabial flap, palatal flap. If it is unilateral lesion, the other side is normal. You just rotate one side of the palatal, greater palatal is tight. The other side is completely kept intact and rotated to the cheek and do a closure. If provided, if you go for extraction of 7 upper molar teeth. So bilobed radial forearm, one single radial forearm from one hand can be made into 2 lobes in the hand itself and rotated inside. One side, each side will have one lobe, and the vestibule will have the pedicle. So this is the one. Tensor facial flap is nothing but your ALT flap only without skin. ALT flap without skin with the tensor facial same vessel, which you can use, very good for your submucous fibrosis. This is the bilobed flap. One side will have your left side, center will have the vestibule, will have the isthmus, other side, and the pedicle is anastomosed to the one of the sides. We can appreciate this, and though it has got delayed healing, this is one of the flaps. No other patient turned from 0 to 25 millimeter of mouth opening. That is one of the advantages with this flap. Tensor facial flap, again, it is based on your descending branch of lateral circumflex. I don't have a post-op of this patient, but it is one of the versatile flap. Very easy mucosalization. Epithelialization takes place very easily, unlike your radial forearm flap. So this is one of the thin flap. They were using for reconstruction of the dura in the craniofacial resection. The neurosurgeons or plastic, they use this kind of your flap for reconstruction of the dura. So rectus abdominis flap, long pedicle. It has got a highest more than 3 millimeter of diameter of artery in the vein. Very easy flap, multiple perforators around the navel, around the umbilicus area. You can check with your Doppler and take a flap with this. Versatile flap, composite, if any kind of composite can be used. We can bend it like this. Initially, the patient will have a bulky appearance on the face. However, when it's subjected for radiation, some amount will undergo liquefaction. The fat will go for liquefaction, and then it gets shrunk to some extent. When no other avenues are there, you can think of this flap also, easy flap. Sometimes you may have Dacron mesh to keep it inside to prevent the herniation of the peritoneal content. When it combines with cheek, GB sulcus, infratemporal fossa, and floor all together, the ALT is again the best option. So instead of going for a bony reconstruction using fibula or iliac, you can think of that. This single flap will line the entire, and you can appreciate the donor side. In this case, we could not achieve primary closure because the patient developed compartment syndrome. Another next slide, I will discuss about this. What will happen if the neck is compromised? You can't do microvascular or other flap. When all flaps have failed and the patient has gone for radiation, again patient recurrence, again you do a surgery and you won't do reconstruction. If you find arterial compromise is there, use transverse cervical, which is below your clavicle. And the correlate loop is done by one of the Indian authors, namely Yatunandan. He has done this looping technique from the opposite side. You take from the opposite side and do that. And common carotid can be considered for doing anastomosis. Make a window on the lateral, as it's seen the blue color window in the photograph. You can use this. Earlier, it was considered as risk for stroke, but there was a backflow from the ECA to ICA. So the chances for stroke is reduced nowadays. So end-to-site anastomosis can also be done using your common carotid artery. If all is not there, think of going for a vein graft. Take from the greater subvenous vein and anastomose with the vessel and elongate the length of the pedicle and bring it down to the thyrocervical, transcervical. Thyrocervical trunk or transcervical or axillary. So long pedicle is very important. That is the main theme of showing this slide. You can't say compromised neck, leave it like this. We can do with so much modification. That is the idea of telling this. And you can do end-to-side anastomosis for the vein. Most of the time, vein becomes shrunken, or sometimes they sacrifice the vein when they do a radical treatment for the neck. In that case, you take from the opposite side and do anastomosis, number one. Second is long saphenous vein. Again, for vein also, you can use it. Interpositional vein grafting can also be used. Cephalic vein can be used. Adjacent EJV can also be used. It has got a same, just to elongate the length of the pedicle, do a tension vein anastomosis. And when you do these kind of anastomosis, two sets, two venous anastomosis has to be done. That is very important to get adequate drainage. See, for 1 gram of tissue, 8 ml of blood should go inside the flap and come out per hour. 1:8, remember. 1 gram of tissue, 8 ml of blood should go inside and come out. For that, we need good amount of scavenging from the flap. So choose bigger vein to do anastomosis. So the suction will be more. We can completely evacuate all the impure blood from that flap. So internal memory, how to harvest, we make a window on the 5th rib, 3rd, 4th, and 5th rib, and then it's little cumbersome. Never tried this, but just for the sake of your, for your knowledge, just I'm sharing this. All the flaps have been tried, all failed, radiated, injured, and osteonecrosis. The last avenue will be a lattice dorsal flap. So again, it is a pedicle flap. No need to think of going for a microvascular. So we did one. Of course, we don't have a post-op outcome. It was a good results we have got. So lattice dorsal in the axilla, you can rotate it and close both sides. So anastomosis, which could be used, microscope has to 12.5x magnification, better precision. You can even furthermore magnify that according to your convenience, and fixed. There won't be any shaking. All focal length, everything is fixed. Coming to the loops, 3.5 is the maximum you can use. When you use 4 or 5, your field of vision will become restricted. That is one disadvantage. Second is portable. That's an advantage. Third is the focal length keeps on changing. When you use the human nature, you just bend, the focal length will change. Again, you have to go back and do it, which is not happening with a microscope. Prefer microscope if possible. Otherwise, go for a loops. So what to use? TU2 or 9O monofilamentous round body atraumatic needle, simple interrupted end to end, and continuous only for end to side. It's more important. End to side vein, most of the time you prefer end to side anastomosis, which give a assured outcome. So try to do either common facial vein or your IJV for end to side anastomosis. Advancement, we are not suing always nowadays. Vein, we do some other modification, non-suturing techniques. Since 2011, we are practicing. One is the coupler anastomosis. Of course, in this case, we have used for artery also couplers. Is doing very well. And another is the stapler anastomosis. Micro staplers are used for anastomosing the vein. No time will finish the anastomosis instead of suing this. Preparation time is less, ischemic time is reduced, and operating time is very much reduced. The third is the diode laser, which is used for your soft tissue in the periodontics. It can also be used in this. This is again welding two ends of your vessel with methylene blue. We have that article that will share it in the group or whatever it is. You can go through that. So whether to give anticoagulation or not, local irrigation is the best. For dilatation of the vessel, you just keep on irrigating diluted 4% lignocaine. Loxicod, the cardio-friendly drug. Don't use with preservatives. It is not good for this thing, and should not be given in higher. See, anything which is given in higher concentration becomes vasoconstrictor. So xylocaine is a vasodilator basically. Bupivacaine is a vasodilator basically. When it given in a higher concentration, it becomes vasoconstrictor, the other way effect. So dilute it properly, and not more than 20 ml should be given for irrigation in the patient. If it is not there, comfortably use low molecular weight heparin diluted with ringer lactate. 1:10 ml, you can irrigate confidently, especially when and distal flap heparinization. That is, you take the heparin, inject into the flap, after harvesting the flap, inject into the artery. Just give a pressure into the artery and clamp. The heparin is inside the flap now. It is acting as a anticoagulation action. Action is taking place until you do anastomosis. Once you release the anastomosis, the flow is good. The color of the flap will be very fine. So distal flap heparinization, we published in the Indian Journal recently. You can go through that. And systemic heparinization not greatly help in the flap survival. It helps for prevention of DVT. Elderly patient, obese patient, diabetic, female patients are prone for DVT when they are in a prolonged bedridden time. 10 hours, 12 hours surgery. Again, next day the patient won't be able to get up. So prolong that can precipitate your DVT. To prevent that, this systemic heparinization will be useful. Now, how to check the flap, whether it is viable or not? It's a bad flap. Giving a prick, gushing blood, black blood. It is not a good flap.
Like that, all the venous blood is coming.
This is a good flap. Color is good. Perfusion is good. Bright red color is coming. This case has got a desquamation of the epithelium. The epidermis is undergoing desquamation. The first sign, the color of the flap become gray and it is getting desquamated. And quick gushing blood, deep blue is coming, which is not good. This is coming slowly, bright red in color, skin texture is intense. Don't rely on temperature. Intraoral temperature will not give any proper result. Without complication, no surgery. So compartment syndrome for this fibula patient. So why we if you are talking about tourniquet time exceeds pressure. How to assess the tourniquet time? Maximum 2 hours, not more than that. If you are not able to harvest in 2 hours, release the tourniquet, deflate completely, wait for 45 minutes to 1 hour, and then you do inflation. Otherwise, don't do it. Number one, how much pressure? Randomly don't keep 200 or 300. Check the intraoperative systolic pressure. If it is 120, twice the systolic pressure is your normal tourniquet pressure for that patient. Generally, don't take 220, 250, 300 like that. Just check the pressure of systolic pressure of the patient. Double the systolic pressure is your tourniquet pressure. That is the ideal. This patient has got the tourniquet. The patient was having some vascular compromise in the leg, which is not detected in the CT angiography. So after harvesting the flap, the patient developed within 24 hours. Patient developed severe pain in the thigh. The patient is not allowing the anesthetist to touch the thigh. So excruciating pain, neurologic kind of pain. And you can see the complete forelimb is completely swollen. And the patient was rapidly undergoing lactic acidosis. It is reflected in the renal function test. Creatinine, everything is. If it is left as the patient has to go for dialysis. So early detection is very, very, very important. Later signs will become a fever, blisters formation. See what happens, we put a bandage over the leg, right, to dress the wound. So you won't be able to see all those things. So this pain is the first, and if it is severe pain, then definitely completely remove the bandage, elevate the leg and see. If it is not subsiding within 24 hours, take the patient for a fasciotomy. This is the second is the fasciotomy. Just decompress, make incision over that. All the content will get evacuated and keep it drain. Pressure suction drain is kept inside. Motorized drain is kept inside for 48 to 72 hours. Completely getting rid of this pressure. Once the patient, then you don't do a primary closure, you do a SSG. See, this is not to threaten, this is just one of the rarest complication happens. I'm seeing in the all 20 years, I'm seeing second case. So donor site complicated, proper evaluation is important as well as fast surgery is very important. Microvascular need very faster performance. Anastomosis, everything, not more than 2.5, 3 hours maximum flap ischemic time. You should completely get rid of this, come out of the theater. That is very important. And some of the other complications, the radial foramen has got a very bad donor site morbidity, but then it heals spontaneously. It doesn't require any treatment at all. Just keep that area aseptic, just give a proper dressing, that is enough. So these are the reference I would like to insist for the consultant as those who want to pursue microvascular or any flap. These are the, at least go through this. So the Greenberg will give how to manipulate the implants or hardwares according to the flap. Grab ends in and out of everything is given in these books. At least these kind of books should be read by the PGs and consultants, those who want to take as a career. Thank you, Kerala, once again for this excellent time, for allowing me to sharing all the inputs from my side. Thanks a lot, one and all.
Thank you, Senthil sir. That was a very wonderful and exhaustive lecture. And the wide variety of your cases itself shows how you became the master of this in this area. So we have a few questions, sir. Let me ask one of. I'll start with my question first. Actually, during fibula, after fibula harvesting, how long will you immobilize the leg? And do you put a slab or just dressing on the donor side? Fibula.
A POP slab.
Yes, sir. POP slab.
Obese patient, I insist to put that.
Okay.
The posterior alone, not the anterior.
Okay.
Otherwise, I put the crab bandage only.
Crab bandage only. Okay. Same, sir. Yeah. So we have few questions from the audience side also.
Please, please.
The first question is like, while using fibula, when you do a hemimandibulectomy with condylar disarticulation, how will you reconstruct the condyle with the fibula? Do you keep it free, or do you put any interpositional graft in between?
Two options. If you want to keep it free, much away from the fossa.
Okay.
Second is either you go for a reconstruction plate with the condyle, or go for a condylar, what is that? Condylar prosthesis.
So, in a malignant case, in a oral cancer, with the condylar processes, do you expect
definitely, no, definitely process not advisable.
Yeah.
For benign lesions, I'm telling.
So in a case of benign case, you will go for process. Otherwise, you keep the fibula end free. Is that correct, sir?
Yeah, much away from the fossa. Much away from the fossa. Cantilever.
Yeah. To my understanding, the thing is that when you do a condylar disarticulation, we make sure that we preserve the articular disc if you are putting a fibula. Do you follow that technique, sir? Or you remove the articular disc also? Is there any difference in that?
If you are putting a reconstruction plate.
No, not plate, sir. We are putting a fibula end and the condyle. Do you preserve the articular disc?
It is not reaching the. If I am cantilever fibula, I can go up to that area, much away from the fossa only.
Okay.
Because it is not going to give the shape of the condylar function of the condyle.
Yes.
So keep it away from that so that the heating will not cause any pain.
Yes, sir. Thank you. We have one more question, sir. The patient, he has asked about his own patient. He has a patient who was operated on anterior mandible, where a skin flap is placed, and the patient wants rehabilitation, probably dental rehabilitation. And what is the best option for him? He has not mentioned whether the mandibulectomy has done or not, and which flap is placed. Basically, he's asking about a dental rehabilitation for an anterior mandibular defect.
Fibula can be, you can put a fibula only.
Yeah.
I can understand. It is a resection.
The question is not clear, sir. The question is very vague. That's the thing.
Yeah.
It's okay. It's okay.
Segmental or peripheral, I don't know.
Yeah. He has not mentioned whether what mandibulectomy, what flap, nothing is mentioned. So question is not very clear. But question was put by Munish Kumar. If you can clarify the question in the chat box, we can discuss that. Okay.
Sure.
Yeah. We have one more question, sir. Regarding PSI. So what should be the ideal height of mandibular PSI for functional dental implant rehabilitation? That's a question.
For PSI, what we observed is you make it as two components. One is the housing with the plate, right? You make like a reconstruction plate slightly with a good, what is that? With good gauge. They say that some good quality of your titanium. You should have housing in that. Separate abutment. After 3 months, I showed in the nasolabial flap. My case and all, it is not in toto. It is not with your abutment. Your housing is separate and abutment has to be loaded later. So we leave it like how you do for dental implants for 3 months, 4 months like that. We leave it like this and then you do a restoration. The problem comes only the exposure. Primary exposure of the plate will land up with the infection. So we completely close with the soft tissue. Make sure adequate soft tissue is there after placement of your PSA. And make sure the PSA is fabricated in such a way that the housing is there, but the abutment is not is separate. Abutment as how you do it for dental implants only you have to do it. So driven type or whatever it is. So that is safe for doing your, that is one. Second is long defects is very difficult to, it's very cumbersome for the patient to wear for a long time. And the long defect, for example, angle to angle, I find it difficult for, without flap, it is difficult for a PSI to live.
Yes. Thank you, sir. Sir, one more question. Sir, during fibula, do you place the dental implant on table or after the patient has completed the whole treatment, like for example, the patient will go for radiotherapy. So
Radiation patient, we don't put the primary implant placement. We encourage primary, for all benign lesions, we put the primary implant.
okay.
We harvest the flap in the leg, we do carving everything, fabricate everything, and put a dental implant in the leg itself before dividing the pedicle.
Yeah.
So we just take the pedicle into that, just fix it and do the anastomosis. That's all.
Yes, sir. Okay.
That is giving good results.
Yes, sir. Okay. Okay.
Sir, may I come in?
So another one, we have one more question, sir. Can you give some methods where we can monitor a buried free flap, like in case of fibula without skin pad?
Yes, we for most of the benign lesions we do that only.
Mhm.
We bury the flap, and we sometimes we don't take purposely. We don't take skin at all.
Okay.
We take the flexor hallucis muscle and connect with your mucosa.
Yes, sir.
So at one point of very soon it get epithelial with the mucosa. If you keep a skin, the skin will, the purpose of taking skin for benign lesion is just to monitor the flap.
Yes.
If you want to monitor the flap clinically, using keep the skin out of extra hourly, you can keep it. After 10 days, you discard under LA or whatever it is. Try to avoid keeping inside the oral cavity unless otherwise it is indicated. And you just bury the flap, and bone scan will be ideal for assessment of the vitality of the flap. Number one. Second is implantable Doppler. We never used it, but implantable Dopplers and indocyanine green are there. Inject the dye into the blood vessels. The dye will stay in that area for 4 or 5 days. So you monitor with your scan. If there is any interruption in the blood flow, that is reflected in the fluorescence dye. So these are 3 methods. We never tried, but we have done a lot of bone scans for that. Bone scan, the main disadvantage is the cost, and second, you have to ambulate the patient, immediately shift the patient immediately to some other center. We won't be having bone scan in all centers, right? So we have to transport the patient to the different center, and then you have to take it. That is very reliable. Even the article publications are looking for a bone scan rather than going. The skin scratching is not a perfect way of. Sometimes you'll get a false negative also.
Yes, correct. But as you said, the first scenario where you place the FHL, flexor hallucis, that will be that is a very simple and easy.
Yes, easy.
Even then we can monitor even with the color of the muscle.
Correct.
That's what yeah.
Easy.
Yes, sir.
Easy.
I think.
Sir, may I come in? If you can hear me?
Yeah.
Yeah.
Hi, Dr. Senthil. It was a nice presentation. I think you had too many topics to cover in an hour, 40 minutes. But my question, which was put by the moderator, was slightly unclear because there were too many things to write about. So I just concised it and put it in. The patient came to me was with the interior mandible CA, and he had some floor infiltration also probably, and he was treated by a plastic surgeon in AIIMS Bathinda. I'm from Punjab. Now the patient has come to me without any reconstruction plate, and he is both sides are mobile, and his primary concern is that he is unable to chew anything, obviously because his mandibles are not united. So now my question is, what is the best thing I can do for him? It is almost 2.5 years since his radiotherapy, and all his treatment is over. Now, what is the best option according to, as you already said that prefibula graft is one of the things, but at my place, we are not into microvascular. So anything else can be done?
Yeah, the only option, the best option for cancer treated patient will be your vascularized flap only, sir. And then,
Okay.
I would suggest you to go for a PET scan now. The
Okay.
advantage of PET scan is dual. One is you can rule out recurrence, number one. And second is the viability of the bony edges, both bony edges. That should be adequate. That is best revealed in your PET scan is nothing but your bone scan, same principle only. So you'll come to know the vascularity of the existing bone. If the vascularity is very good, the vascularity is very good,
Okay.
and distal and proximal are intact, and the size of the defect is 6 centimeters or less than that, you can confidently go for a free graft also. No need to go for a free flap. Flap only difficult, right? You need lot of working hours, all those things. Graft can be taken. Graft is one of the best options that you can do. According to your statement, assuming this is a segmental defect, which is involving the lower body up to the lower.
Yeah, maybe.
So, and size of the defect matters, sir. Size of the defect is less than 6 centimeters. You can confidently go for your radiation is over, and make sure it is not that before that you take a bone scan. If the bone is the existing bone, mandible is good or not. Vascular.
Do you put bone non-vascularized bone graft in a irradiated area?
I strictly insist on free flap only. But then this scenario, it's more than 2.5 years old. I assume it is young patient, and you can go for your bone scan and find out the vascularity of the existing bone. If that is not a problem, then you can try that also. It is mine. I can't say this is the best. It is always the best.
Now the second part of my question is that the skin graft which is already in the oral cavity, how do get it to the keratinized mucosa, or do I need to replace that skin graft with any other local buccal flap, or maybe some other?
If you are going for a free graft,
nasolabial flap.
No. If you are going for a free graft, don't explore intraorally, sir.
Okay.
Go from the down, anterior mandible, submental, horseshoe. Try to prevent reaching of the mucosa. Even your skin graft, whatever it is, let it be like there only. You just keep the strut in the between the two remnant mandible and fix it extraorally. Or try to avoid exposure of free graft intraorally. For that any matter, because they say all are intramembranous ossifate bone, mandible, maxilla, everything. And cartilaginous bone, you take from different side, you have to take more than what is required. That's the Philip Boyne's theory of.
Obviously.
So either you have to take calvarium, which you can't take it bicortically. Ramus or all those things small only. Such a huge defect you have to take from iliac crest or your fibula. Both are originating endochondrally. So you have to take what is required. And being a bone graft, you should not get exposed into the oral cavity. Will eventually go. That will melt.
We have one more question, sir. For arch mandibulotomy defect, that is anterior mandibulotomy defects and lateral defects, after fibula osteotomy, which plate do you prefer for fixation? Do you prefer mini plates or recon plate?
Mini plates.
Mini plates, yeah. Obviously, because even recon plate will expose. That's
exposed.
Yeah.
And if you're putting a
Sir,
reconstruction,
before I think
Well,
before we run out of time,
please,
one final point. I just
please.
want to make one point, please, if you allow me.
No, but please,
Moderator, sir,
could you
can I speak?
put your comments in the chat box, because we don't want to interrupt the session in between. So could you put your comments on the chat box and we will discuss over it. Is that okay with you?
Okay, great.
Yeah. Yeah. So do we have any more questions? So Senthil sir, do you do any other local flaps for maxilla? You demonstrated the fibular techniques. Do you do any other local flaps like temporalis?
superficial temporalis, not the temporalis proper. Superficial temporal flap.
Okay.
From the temple, fascia cutaneous, based on your superficial temporal artery and the vein, rotate it and keep it inside.
Okay.
For orbit floor or your maxilla is ideal.
Yeah.
Aesthetically won't be applicable because you have to put a SSG over the temporalis muscle, because we are not doing take the temporalis.
Okay.
So better to go. Aesthetically won't be appealing, but still being cancer defect is better to go with that.
Yeah. So I think there are no more questions from this thing, and we had like more than around 9. Yeah, we have one more questions coming. So during flap monitoring, should we scratch it at the same place or should we keep changing the place of scratching?
That
So-
doesn't matter. One place will not have a bleeding, bleeding will be there. Another place, that time matters.
Okay.
5-10 seconds, slow is normal.
Yeah.
Should be bright in color.
Yeah.
Skin texture will be the same.
Yeah.
Yeah, those things. We remember the donor site colors of the skin and the present state. Volume, the bulk of the flap increases, there will be a congestion. Take apt size for skin flap. Don't take too much of flap, even ALT or it will be tempting to incorporate all the perforators in the flap and take it. But still, while placement of the flap, trim it according to your convenience, according to the size defect. Don't take too much. And when you keep, while suturing, you keep the mouth open and suture. At the time of closure, the flap will sag again.
Yeah.
So these are practical tips that we need to be understood.
Yes. Those things will be learned only from experience.
Correct.
Yeah. Yeah. So I think it's late in the night, and we have, sir, for a wonderful session. We have almost 92. Now it is coming down towards your conclusion slide. There were 92 participants there. That explains how interesting your session was, sir, and great. We are very grateful to have you. Thank you very much.
You conduct very nicely.
Over to you, Akhilesh, sir.
Sorry?
Okay.
I
Thank
don't
you,
know.
Sudheesh.
Over to you.
Thank you, Senthil sir and Sudheesh, for that wonderful session and wonderful discussion part. I hope our participants have got all their doubts cleared. And we had something like 140 participants, and towards the end, it was like something like 100, I think, the end of this thing. And still, we have about 50 participants. And I wish, thank you all for attending the session. And thank you all for your feedback also. Sorry, sir.
Somebody has asked for my number. You please share with them.
Yeah, I'll surely share it. Munish sir, no, I'll share it with him. I'll send it to you, sir, Munish sir.
Thank you.
Thank you all. Have a good night.
Thank you.
Thank you all for joining. Have a webinar next week. Thank you all.
Thank you.